E4V5M6 normal. SpO2 was 96% in room air, and heart rate was 156 per minute. The chest was normal. Bilateral air entry was present, and the respiratory rate was 28 per minute. On cardiovascular examination, the S1, S2 were present, and S3 gallop was heard. S3 gallop usually signifies the ventricular rapid ventricular filling after the S2 sound. Blood pressure was found to be 106 upon 68 mm of Hg. That is more than 90th percentile for that age group. The blood counts were 14,000. Leukocyte counts were 14,432 per cubic millimeter. The differentials were neutrophil 68%, 30% leukocytes, and so on. The CRP was found to be 19 mg per liter. The reference range was less than 5, and urea creatinine was in the normal range. This was a chest X-ray of the patient that shows cardiomegaly, probably due to. Now, with the introduction, the acute heart failure is broadly defined as rapid onset of a new signs and symptoms of the heart failure. That is called a de novo acute heart failure, or the worsening of the signs and symptoms in a pre-existing cardiac dysfunction. That is called acute decompensated heart failure. The de novo acute heart failure occurs when there is a sudden increase in the intracardiac filling pressure or acute myocardial dysfunction leading to the diffuse peripheral perfusion and pulmonary edema. The most common etiology of this kind of acute heart failure is cardiac ischemia, where the contractility in the myocardium is decreased and subtended by the affected coronary artery. The acute decompensated heart failure, the medical comorbidities like diabetes mellitus, renal dysfunction, non-compliance to the medications, infections, and polypharmacies like NSAIDs, thiazolidinediones, and others contribute to the sudden deterioration of the signs and symptoms in a pre-existing heart pathology. This constitutes the majority part of the presentations of acute heart failure. De novo heart failure and acute heart failure. De novo heart failure is like an undiagnosed underlying cardiac condition along with the precipitating factor or a new onset cardiac dysfunction. And acutely decompensated heart failure is chronic underlying cardiac dysfunction along with the precipitating factor. They lead to the left ventricular diastolic or left ventricular diastolic and systolic dysfunction, which leads to the pulmonary congestion, which further leads to the right ventricular dysfunction and causes a systemic congestion. That's how the disease progresses. Physiological patterns of acute heart failure. Hypotension or hypotension or tachycardia with narrow pulse pressure or cool extremities and irritable or decreased consciousness. Then we need to assess if the perfusion is low or not. If the perfusion is normal, then it comes under the warm and dry. If the perfusion is normal and the congestion is also normal, well, there is no perfusion is normal, but there is no congestion, then it comes under warm and dry. If the perfusion is present, but the congestion is the no congestion, that comes under cold and dry. If the perfusion is normal and the congestion is present, then warm and wet. And if the perfusion is low and the congestion is present, then it comes under cold and wet. This is also the same. The pathophysiology of the heart failure, the inefficient pump, when there is inefficient heart contraction leading to, then it leads to the responsive adaptation by the heart. But the adaptations might be insufficient or it might be the maladaptation. This leads to long-term disease progression. But inefficient pump can also cause acute exacerbation, and inefficient and maladaptations along with the long-term disease progression can cause acute exacerbation. The classification of acute heart classification of the pediatric heart failure based on a modified Ross classification. It's based on the symptoms. Class 1 heart failure is asymptomatic. Class 2 in infants, mild tachypnea or diaphoresis is present. In older children, dyspnea or moderate exertion. Class 3 heart failure, infants marked tachypnea or diaphoresis with feeding difficulty, and in older children, dyspnea on mild or minimal exertion. One. Class 4 heart failure. Can we take it, please?